Hi, everyone. My name is Danielle Gatti Palumbo, and I am a clinical pharmacist at Northwell Health Division of Rheumatology in Long Island, New York. And today we'll be discussing Voclosporin, how it's dosed. Are there any special considerations regarding administration, dose adjustments, as well as drug interactions? So Voclosporin is a calcineurin inhibitor that's FDA-approved for the treatment of lupus nephritis in combination with immunosuppression, such as glucocorticoids and mycophenolate. The safety and efficacy has not been established with cyclophosphamide. A little bit about Voclosporin is it is a capsule. It comes as a 7.9 milligram pinkish kind of capsule. It is dosed at 23.7 milligrams by mouth twice a day, so patients would need to take 3 capsules twice a day. It should be separated 12 hours apart or at least 8 hours apart. If a patient misses or forgets to take a dose and it's within 4 hours from their missed dose, they can take it as soon as possible. If it's more than 4 hours have lapsed, then it's recommended to just skip that dose and then go on to their next dose. It should be taken on an empty stomach, swallowed whole, do not crush, do not pierce, do not try to open, and avoid grapefruit juice. Now, regarding special considerations, especially dosing adjustments, Voclosporin for hepatic insufficiency. With those with mild to moderate hepatic impairment or a Child-Pugh class A or B, the dosing adjustment is to be dosed at 15.8 milligrams twice a day. For those with severe impairment or a Child-Pugh class C, it is not recommended. Now, before initiating Voclosporin, it's important to monitor eGFR as well as baseline blood pressures. Renally, this is a calcineurin inhibitor, so there is a risk of calcineurin inhibitor nephrotoxicity. So prior to initiating, you want to evaluate your eGFR. It has not been studied for those with an eGFR of less than or equal to 45 mLs per minute, and therefore they were excluded from the study due to the risk of nephrotoxicity. However, the manufacturer does state that there is a risk versus benefit, so if you do choose to use it in those patients, they use creatinine clearance. Those with a creatinine clearance of greater than 30, no dosage adjustment is required, but those that have a creatinine clearance of less than 30, then they recommend the dose to be 15.8 milligrams twice a day. So you do want to reassess your eGFR every 2 weeks for the first month and then monthly thereafter. Now, while a patient is on therapy, you may have to dose adjust based on the eGFR. If the eGFR falls below 60 mLs per minute and is reduced from the baseline by more than 20% but less than 30% from baseline, you want to decrease the dose by 7.9 milligrams twice a day, so 1 capsule. You're going to reassess the eGFR in 2 weeks, and if it's still reduced by more than 20%, you want to further reduce the dose to 7.9 milligrams twice daily, so 1 capsule twice a day. If the eGFR is less than 60 milliliters per minute and the eGFR is reduced from baseline by more than or equal to 30%, they recommend discontinuing therapy. You want to reassess the eGFR in 2 weeks and then consider reinitiating therapy if the eGFR returns to more than or equal to 80% from baseline. And at that point, you can also reinitiate at a lower dose of 7.9 milligrams twice daily. If the eGFR is less than 60 mLs per minute and is reduced from baseline by more than or equal to 30%, they recommend discontinuing therapy. You want to reassess within 2 weeks and consider reinitiating at a lower dose of 7.9 milligrams twice daily or 1 capsule twice a day, only if the eGFR has returned to more than or equal to 80% from baseline. If at any point in patients that had a decreased dose due to their eGFR, you can consider increasing the dose by 7.9 milligrams twice a day for each eGFR, that measurement that is returned to more than or equal to 80% from baseline, not to exceed the recommended daily dose of 23.7 milligrams twice a day. So you can go back up if the patient does have that return in their eGFR. Now, regarding blood pressure, you do want to monitor patients for hypertension emergency, and you don't want to initiate this if they do have hypertension of emergencies or anyone that has a blood pressure of greater than 165 over 105. So you want to monitor blood pressure for the first 2 weeks for the first month, and then when indicated thereafter. If at any point the blood pressure does increase to greater than 165 over 105, or the patient has a hypertensive emergency, you want to discontinue therapy and initiate antihypertensives. Other warnings and precautions with this medication. So you do have the nephrotoxicity, so you want to monitor eGFR closely. You do have the hypertension, so you want to monitor blood pressure. and initiate antihypertensives if required. There's also neurotoxicity monitoring, so monitoring patients for PRES syndrome, delirium, seizures, tremors. Some patients may require a reduced dose, or you may have to discontinue therapy altogether. Hyperkalemia also for this medication, so monitoring potassium levels, especially in combination if there's other medications that they may be on that also potentiate potassium levels. QT prolongation, so consider EKG monitoring, especially if patients are on other medications such as Plaquenil or so. That can also potentiate the QT prolongation. You want to avoid live vaccines, and particularly with voclosporin, with pure red cell aplasia, you want to discontinue therapy. Pregnancy, it has been shown to cause fetal harm in animal models, and it is not recommended in breastfeeding because it has been shown to be present in breast milk. Some side effects that are common with voclosporin include stomach pain, diarrhea, heartburn, headache, hair loss, the changes in your eGFR, kidney injury or renal impairment, anemia, as well as cough, UTI, oral ulcers, fatigue, tremor. Other patient counseling, you want to make sure that you counsel patients on the risk of infection because this is an immunosuppressive agent. There's also the risk of lymphoma and other malignancies, as well with like any other immunosuppressive therapy. So you want to make sure that you counsel patients on exposure to sun, limiting their exposure, using UV protection and sunblock. Drug interaction-wise, it does go the CYP3A4 pathway. So it is contraindicated with strong CYP3A4 inhibitors such as ketoconazole, clarithromycin. With moderate CYP3A4 inhibitors such as verapamil, fluconazole, or diltiazem, you need to reduce the dose to 15.8 milligrams in the morning and 7.9 milligrams in the evening. For those with mild CYP3A4 inhibitors, there's no dosage adjustment, and there may be a reduced dose that's needed for medications that undergo the P-glycoprotein substrates. So I hope that's a really concise medication review for you. And if you want more information on voclosporin or other drugs, you can visit our website at rap.org and click on that room content. Thank you.